Okay, so we have two cases here. What I'm going to do is show you. Can I have the first case? The first case is a very interesting case. It's a case of Burgess disease. And this patient actually is a chronic smoker, and what we did earlier was he had no flow in the infra-popliteal region on the left side, and what we did was we actually did an autologous stem cell implantation because he had no other therapy. He was having a critical limb ischemia with the impending gangrene, and in fact he had gangrene for which 2 toes were amputated. And after that, slide दिखाओ, उसको वाला वाला दिखाओ ना, couldn't think. So after that, we did an autologous stem cell implantation. This was about 2010, 7 years back. That time it was an approved therapy in India, and this patient actually did very well. And this time he has come with a critical limb ischemia of the right side. So I'm going to give you the first shot of the angiogenesis, and you can see it really works. Okay, go next. So this is the left side, 7 years back, treated with the autologous stem cell implantation. You see a bunch of collaterals. You see this corkscrew appearance of the collaterals, which is quite typical angiographic appearance of new angiogenesis. This patient's the limb was saved because of this autologous stem cell implantation. Go next. Next.
So you say that was in 2007?
This was 2010.
10. Okay.
This is now 7 years after that. And of course, the patient has stopped smoking and he's walking and he's put on a strict walking regimen. So these limbs, just to show, can be saved. And after that, what has happened is he's got a critical limb ischemia because of popliteal stenosis on the right side. And that is what I'm going to show you. How we did this autologous stem cell implantation was done during our third Asia Pacific Vascular Interventional course, and where we demonstrated it live, and this is the follow-up after 7 years. Go, show me. So this is the right side. We did an angio about a week back, and you can see there is a critical stenosis in the popliteal behind the knee, and this is definitely was a no stent zone unless we had a vasculomimetic implants. And the only option, good option here would be either do an atherectomy or a drug-eluting followed by a drug-eluting balloon, or we go ahead and do good dilatation and a vasculomimetic implant, which we have done in this case. I just wanted to show now we have a technology by Abbott, the Supera stent. Just hold on. The Supera stent, which actually leads to, is crush resistant and can take the bends of the knee joint. And it has a very good, crush resistance, and it has almost no fracture rate, and a patency of about 87 to 90% in primary settings. So what we did, So what we did is we have gone contralateral from the left to the right. This is a road map. We always do our interventions on the road map, and on the road map, what we are doing is we are passing in a 014 wire. Next. And after that, we have pre-dilated this lesion. Next, go next. See, you can see the lesion. Go next. Okay, so we have pre-dilated the lesion with a 5 millimeter balloon. What is very important in Supera implantation is it's very different from other implantation, that we need to dilate the vessel little 0.5 to 1 millimeter more than the size of the vessel or the stent which we are going to put. So this appeared to us like a 4.25 millimeter popliteal artery, and what we have done is we have dilated with a 5 millimeter non-compliant balloon, and after dilate, because this creates the bed very well, and then it's easy to implant the Supera. Otherwise, if you do not implant the Supera without a good pre-dilatation, what happens is the stent doesn't expand properly. It leads to foreshortening and elongation, and this does not translate to good end results and long-term results. Go next. So this is the technique. So you can see after the pre-dilatation, the popliteal artery has opened well, and now we are ready to put in a Supera. The size which we chose was a 80 millimeter into 4 millimeter Supera. And if you see the Supera stent, what happens is the supera is, it's like 0.67 more than the size of which is labeled. So a 4 millimeter supera is actually 4.67. And the way we sort of implant this is that you have to very gently go on expanding and releasing the stent so that it doesn't elongate or it doesn't foreshorten. This stent can be stacked or elongated, but if you stack and elongate, the restenosis at those points is higher. So what is very important, while you are deploying, you have to deploy a half centimeter by half centimeter in each step, and the cells have to open in a proper diamond shape. So that's what I have recorded. You can see step by step. Next. Next. So this is the supera stent in position. You have two markers. The proximal and distal marker are the markers on the sheath, and this will give you where the stent would be deployed. But as you keep deploying, these markers move back. So then these markers are of no value. We have to actually put the marks on the screen. Next. Now while we are deploying, we have deployed the first segments, and you can see we are opening it very slowly, step by step, so that the diamonds are equally sized. Next. 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 So while you are seeing this, the geometry and the configuration should not change, otherwise the stent loses its vasculomimetic properties partially or completely. Next. Next. And once we have fully deployed, we unlock the last holding button, and then we deploy the stent. Next. And then we capture the nose cone. Next. And this is the final result. So you can see the next. This is a beautiful next. Final result of supera. Next. Hold it. So this is actually a stent made for popliteal artery, made for no stent zones over the popliteal and sometimes even over the femoral artery, common femoral. And this is, I will show you, we also bended the patient's knee and made him flex the knee on the table, and you can see there is no compression, there is no kinking of the stent. Go next. So this is while the knee is flexed on the table, and you can see it's a very smooth contour. There is no flexion, there is no kinking of the stent, and it has been very well deployed, and there is absolutely no foreshortening or elongation. So this is how a supera is implanted. The techniques are practically similar to drug-eluting stent when we implant. The only thing, if you prepare a bed well, we don't post-dilate these stents because these stents have very high radial force. And the crush resistance is almost 4 times higher than any self-expanding stent. So in today's time, it is a stent which competes with atherectomy and drug-eluting balloon over no stent zone, and I think in today's time, this is the stent for popliteal artery. So this was the first case, and then if you are okay, if there's any questions, after that I'm going to go to the next case.
Well, yeah, just for a moment, let's discuss this just for a moment here. So this was a beautiful demonstration, nice result, and the stent does perform in flexion areas very well. So the question is do we leave nothing behind today, and do we do atherectomy and DCB or something like that in situations like this, relatively short segment disease? Or do you commit the patient to a stent as your first-line approach? Why don't we just open that up and have some comments from the panel? Please.
I also personally feel that it should be atherectomy or a balloon with a drug-eluting balloon as the first approach rather than stent. Stent should be, I think, very long occlusions. And in this case, it has been done very well, no doubt. But first approach should be atherectomy with DB. Maybe this.
I think it's a very short segment. It is not a long lesion.
Yeah.
It's a very short segment. It would respond very well to a drug-eluting balloon. That's what I feel.
Mm-hmm. With or without atherectomy, either way.
Yeah, I think a primary strategy of DCB would be nice, with or without atherectomy. And if you get a good result with DCB technology, I think it would be a nice initial step, and then you can come back and do supera in the back. But if you dissect with DCB, you still have that access to supera, and I think the combination of DCB and supera may not be cost effective, but is a very reasonable strategy.
Mm-hmm. I also note that, you know, although the patient had limb salvage in the other limb, it did re-occlude, and then you have a stent occlusion. Now, if you get restenosis of the supera to small diameter supera behind the knee, it's problematic to treat the second time. So nice result, but still debatable as far as who would do what here. First approach, I think many of the panelists would say maybe do a non-stent approach first and then reserve the stenting for recurrence risk. Okay, tell us about your next case.
Okay, Shyam, next case. The next case is a 69-year-old gentleman who is a diabetic and had a bypass surgery, coronary artery bypass surgery about 10 years back. And post that he was fine, but he started having claudication in both the lower limbs. And that time, this was about 8 months back, and he came, he had a total occlusion on the left side, which on the right side, which we did, you know, a subintimal angioplasty for a short segment, and then we did a balloon dilatation. And this patient had the first drug-eluting stent, which is the Silver PTX stent in India. And on the left side, again, he had a tight stenosis in the superficial femoral artery, and that was also treated by Silver PTX. He was fine for months, and he had a non-critical Popliteal disease, below knee disease, but now he has become symptomatic and he's got a critical limb ischemia, he's getting rest pain, and we have done an angio today, and what we see today is there was about a 60% restenosis in the Silver PTX stent, which we have dilated, and we have wired, we are going to wire the anterior tibial artery and the tibioperoneal trunk, which has about 70 and 80%, 70% stenosis. Now this patient also is planned for a drug-eluting balloon in the tibioperoneal trunk and a bio-reabsorbable scaffold in the anterior tibial artery. It is a part of our credence study, and this would probably be a demonstration of indigenous BRS below knee, which is the credence stent. It is similar to the Miris stent. It has a 100 micron struts, and it elutes sirolimus at a concentration of 1.25 microgram per millimeter square. And the stent is reabsorbed in about 2 years' time. This is quite similar to the Miris coronary stent. It has a PLLA scaffold, and would be the stent for the indigenous stent BRS for below knee lesions. It comes from a size from 2.5 to 4.5 with the increments of 0.25 millimeter and a length from 8 millimeter to 40 millimeter. So this is what we are going to do. The principles of implantation of the stent would be probably the same. We have a good pre-dilatation, 1:1 pre-dilatation, followed by a stent implantation and followed by a post-dilatation. And the other branch, we are going to do a drug-eluting balloon because as per the protocol, we can only put one BRS and in one limb. So we have to treat the other vessel with a drug-eluting balloon.
So just
I'm going to show you the
quick,
angios, what we have done up till now.
Just a quick question. Great case here. We're looking forward to this. Does the construction of this BRS differ at all from the coronary? And if so, how does it differ? Do you have the strut thickness of 100? Is that about the same or a little more? Obviously, you have bigger diameters.
Yeah, it is almost exactly, it is exactly same as the coronary Miris stent from Merrill. And it is a combination of open and closed cell design. At the end, it is a closed cell design. In between the stent is open cell to give it flexibility and to take tortuous vessels. And the only difference is that here the lengths and diameters are a little longer than the coronary stents. We will have it up till 6 millimeter. As of now, we have it up till 4.5 millimeter.
Great, excellent. We're looking forward to this one. Let's please.
But this is a sirolimus eluting stent.
Okay. So let me just go back and start the case. Wire introducer. Okay, get me the balloon and get me
So
the.
it looks like
torque on the
single
wire.
vessel runoff, the last remaining vessel, claudicant though, right? No tissue loss in this case, is that correct?
This, I think, rest ischemia they mentioned.
Yeah,
Shyam,
okay,
wire
class
दिखाओ
4.
please. Shyam. Okay, get me double mag.
It's a fairly long lesion, looks like about 60 millimeters or
इसको हटा
thereabouts.
दो.
Take a couple of stents. All right, well, this is obviously an investigational protocol with a new
चल नहीं रहा.
device. Most of us don't
हटा तो
have
हाँ
that,
निकाला.
correct? While he's working there, how would you approach this
यार ये फ्लोरो नहीं चल रहा.
with other
इससे नहीं चल नहीं रहा.
technologies? PTA alone?
Yeah, I would do PTA alone. In case of
नीचे
suboptimal
दिखाओ.
result, maybe
ये इसको शिफ्ट करो आगे.
How about coronary
Give me-
drug-eluting
give me-
stents?
Yeah.
Several randomized
Yes.
trials is a relatively proximal lesion, not the longest in the world, could be treated with coronary
दिखाओ.
DES,
Move the
right?
table.
Everolimus eluting being the prototype,
table.
the science, well-proven level
Shyam,
one data.
just move the table.
Would give you,
ऊपर करो.
I think, a better long-term patency with single vessel runoff. Who would do that?
yeah, if
Everybody
the
use
result
that.
is balloon is suboptimal, then I think yeah we should consider that strategy of.
So balloon
Sir,
first
हिलिए
and
नहीं, please.
bailout stent.
आया.
Who would do a primary DES strategy? Actually, I would,
टॉर्क कर.
because proximal disease, relatively discreet,
अरे यार.
would be covered with 2
Idiots.
stents maximum, single vessel runoff, proven
There are
level
things.
1 data, long-term patency is better.
Yeah, I think depending
you
on
come
the
this
presentation, if it is indeed, ulcer
Okay, get me the
or
balloon.
gangrenous disease, then I'd be
2.5.
more aggressive to go
1.1.
after a long-term
20,
patency
23.
with DES. If it's more of a resting ischemia, I might be a little bit more conservative with a balloon
take it
angioplasty first approach.
Interesting,
पकड़ के रखो
okay.
जरा, drag
All
रखो.
right, so only for limb salvage CLI
दे दो,
rest pain.
दे दो.
Claudicants?
You get your stent ready.
This is a Rutherford 4, according to what we've heard, right? Rest pain, but no tissue loss. Still stay conservative with balloon only?
I think I will put in a drug-eluting stent, maybe coronary drug-eluting stent, and this
Eluting
only
stent.
vessel. But would you try to look at the other vessel, try to see if you can do a retrograde approach to find out? Look at a total.
Well, there you
disaster?
go. This is not strictly speaking a limb salvage case. So how aggressive do you get in a situation like that? For me personally, if there's no tissue loss, I'd probably stick with just improving the single vessel runoff and seeing how the patient does, and then with close follow-up. But that's debatable. But most of us
But
don't.
would it not depend on which dermatome or which
Don't do
is disease? Supposing you have an non-hernial ulcer in a dermatome which is not supplied by
Get
this
straight.
vessel. Would you be
Okay,
interested?
so yes,
Light will help.
doing
Go
the
ऊपर करो.
dermatome or driven or
आई ऊपर करो.
intervention
यहाँ
is a
जल्दी ना
debatable
करो.
thing.
She's
And
Holding the wire.
if you look at the literature carefully, when it comes to surgical bypass below the knee, doing the angiosome-based revascularization doesn't lead to improved limb salvage. It's only seen with intervention. And why is that? It's not so clear to me. And the actual
करो.
incremental benefit of angiosome-based intervention versus non-angiosome-based intervention is a single-digit
अटक रहा है
difference.
उसको, ऊपर अटक रहा है.
And
ऊपर दिखाओ.
when you look at CLI interventions, half of those
कहाँ
are
अटक रहा है?
above knee, and only half or
दिखाओ ऊपर.
less are below knee for limb
ऊपर,
salvage.
ऊपर.
So it's kind of a murky area where
देखो कहाँ पे.
the one trial from Japan suggested superiority, but it was only a single-digit superiority, and the
ऊपर.
surgical literature doesn't match with that. So
But,
it's
in this patient, where we have probably a non-critical lesion in the
Fine.
only vessel,
Okay.
what
follow
are we
करना.
aiming
ये
for?
देख नहीं रहा.
We are aiming for a limb salvage. We are aiming for a what? Claudication relief or what?
this is for relief of rest pain, and in this instance. So
And,
in-
हाथ हटा
can
के
we ascribe
अरे
rest
इधर
pain
दिखा यार,
to
ऊपर
this
करो.
lesion when the other two vessels are diseased
आया.
or severely diseased?
कहीं अटक रहा
it
है.
looked to me like it was the only one open,
मुझे दिखाओ कहाँ है.
with collateralization at the ankle. So if it's the last remaining vessel, I could see how this could lead to rest pain. Okay, how are we doing there?
कहाँ से कहाँ तक. कितना बड़ा है. This cannot be. क्या double mag है?
Dr. Khanna, can you enlighten us
We
also
are
on
trying to
what
pass
you're
this
doing?
balloon inside. ये नहीं है.
Looks like they're still working on getting a wire down and crossing. Here comes a balloon. Okay, so we were discussing whether to just do a one vessel intervention or try to do more. I think most of us
Yes,
feel
yeah.
just doing the one
Let's follow
diseased
it from
remaining
there.
vessel is adequate here.
अरे ऊपर से दिखा यार वो शीट से हम शीट के वो वाली शीट दिखाओ you're showing me the stent
What do you feel
other limb
about intervening in this vessel alone?
यहाँ दिखाओ ना
Yeah, I think
मैग हटाओ वहाँ से
if
ऊपर दिखाओ follow it in the sheet
the disease is a rather for class 4,
अरे यार इसको खोल दो please
I think you need to take care of the inflow first. So I think the instant
देखो इसमें, कहाँ जा
restenosis
रहा है?
should be approached first, and I think the
बिल्कुल कर दिया, पूरा।
DCB strategy is as good as any in this case.
कहाँ है?
And then
कर दिया?
ensuring at least one good vessel runoff, I think is going to
ये जा नहीं
be
सकता, इसको हटा दो, वो दे दो
critical.
मुझे।
I think
दूसरा वाला
balloon angioplasty for short lesions would be sufficient, but as we've
Pull this-
discussed
pull the
before,
wire, Dr. Rini. Leave the wire.
patency is certainly not as good as DES. So I would
दूसरा कोई
consider
दूसरा लग जाएगा।
DES, especially if there is a flow limiting dissection after balloon
this
angio.
balloon is not going get me another balloon कहाँ जा रहा है दिखाओ I can't even see this
So how are we doing over there? Give us an update on your progress. Tell us.
we are
where-
trying to pass in a balloon for pre-dilatation we are having some resistance कहाँ पे है resistance
So you have a wire down and
Huh?
now trying to pass a
Yeah.
balloon. So I
it is
assume
getting
you
stuck in
do
the stent
full,
in the liver PTX
I assume in this.
yeah I did a pre-dilatation we
Yeah, I assume-
dilated that maybe we'll have to dilate it again
Yeah, I'm sure it's like the
it is
coronary
getting
trials
stuck
where you have
in
to
the
fully
stents.
predilate. Lesion
Yes.
prep is crucial to BRSs
दूसरा हमको
and
बदल लो।
DCBs. We don't talk about this enough when it comes to DCB therapies. You know, if you're going to do DCB for the ISR lesion, you really have to prep the lesion. And it's true for all lesions you're treating with drug-coated
You need
balloons
it, Dr. Rini.
and or BRSs. And it's clear the literature now would suggest that if you have a 30% or greater residual stenosis before you apply these therapies, you're going to have a higher recurrence risk. So, you
दूसरा
know,
लाभ
a
को
lesion
गर्मों
prep
का लेके आओ।
has come
जल्दी
back
लेके
as
आओ
a
दौड़
very
के।
important thing, and I think has been atherectomy salvation, if you will, in calcified
Don't
lesions.
do anything,
'Cause
Dr. Rini, just
many of
do
these, a balloon prep is often inadequate when you're dealing with calcium. And as we know, as you go down the train here from knee and below the knee, the degree of calcification only increases. And even though it may not be quite as fluoroscopically visible because the vessels are smaller, the actual calcium content in the walls tends to be greater. So lesion preparation only becomes increasingly important as you go below the knee.
दूसरा balloon लगा तुम्हारा कोई
You
balloon
think
नहीं
for ISR, plain balloon angioplasty, atherotomy kind of strategy with cutting balloon or angiosculp or
Yeah, just boy, you know, all
Understanding.
non-drug balloon therapies
किससे वो
seem
balloon दे
to
दो
be inferior to
ऊपर से
drug
दिखाओ।
delivery strategies when it comes to ISR
ऊपर से दिखाओ एक
lesions.
बार श्याम हमको
Whether focal balloons, cutting
पूरा यहाँ से।
balloons, and all those things are any better.
दिखाओ।
They tend to not slip, so you don't have geographic miss. As far as long-term patency, no proven difference. What is better, as I showed in my lecture, is that
जल्दी लाओ।
applying atherectomy with the laser
इधर पकड़ो
improves
उसको।
the balloon
इधर
result
पकड़ो।
for an ISR
ला दो
lesion. Time didn't permit, but there was one other study I wanted to show that
2.5 नहीं है
demonstrated the laser before drug-coated balloon also improves the drug-coated balloon result in ISR. One single-center prospective
Yeah,
randomized
go
trial. It's limited data, but what's out there would suggest that debulking facilitates drug-coated balloon effectiveness when it comes to ISR lesions in a couple of different settings.
Another problem is that most of these infrapopliteal vessels are diffusely diseased.
Yes.
You may have a problem in sizing the stent for
Don't do
those.
this.
So you have any experience on IVUS to find out the size of these vessels before you choose the size of the stent for these vessels?
Absolutely. You know, Ivis is your friend when it comes to
Hold the
proper
wire.
sizing, especially when you're dealing with varying diameters and
Look, जो मेरा
difficulty
हाथ
with
छोड़ दे।
angiographic visualization. Use it frequently. And of course, on BRS, they're probably using
The drag
OCT
also.
for this. I don't know if that's mandated in this below-the-knee trial, but certainly it's, as we know, it's your best visualization tool for the coronary application. But either one, you know, gives you a much better appreciation of true vessel diameter.
मेरा हाथ हटा के यार श्याम प्लीज दूसरा साइड देखो यार ये लाइव केस में तुम साला हाथ फ्लोरो करा रहे हो
Looks like a pretty steep
Yeah.
up and over. Doesn't help, huh? Makes it challenging.
या हाँ
So while he's working away, looking at a steep up and over, and this is predominantly a below knee case, who would approach this antegrade?
दिखाओ
Would anyone do this when
यहाँ
antegrade?
दिखाओ
That's assuming you already had diagnostic images and knew what you were up against.
कहाँ पे ऊपर
I would address them, especially if I'm going in for popliteal. I would.
वायर है
Popliteal and
Right,
below
antegrade.
antegrade. Yep, yep.
Mhm.
Who else?
Copy.
Me included. I frequently do that unless there's very obese,
दिखाओ
you
सेंटर
know,
करो
and it's a challenge to go antegrade.
पैर अंदर करिए सर
But it can make it a lot easier. And,
Dr. Khanna, what size balloon is there? I think you have got it now at the site of lesion. Is that right?
yeah almost there but it is 2.5 I'm going to pull it back a little
so this is the BRS or yes, or the balloon?
It's plain.
no this is the balloon for pre-dilatation
Pre-dilatation.
Okay, 2.5. Looks like a big vessel.
yes no this is a double mag
Okay.
okay so this position looks okay
Yes.
go to the normal mag
Would you be concerned about stenting this area once one branch is coming from there?
No.
Cause of concern for you? No.
yeah I'm not concerned because so this is the normal mag oh
Now,
I
BRS
think it
could be
ruptured.
a different issue. I mean, thicker struts
Same
and so
karo.
forth. With standard coronary DES, wouldn't be a problem. And then usually, you know, these are vessels that are 3 to 4 millimeters frequently, and
सेव कर लिया था
you can cross the side struts and the
DSA?
jailed side branches pretty readily. Tends not to be a problem.
okay give me a bigger balloon hold इस पे लगाओ 2.5 now we dilated but this I think there was some calcium there so this balloon ruptured so we are going to change this to another balloon
Might be a case now for a scoring or focal balloon. Either, you know, chocolate even is a good therapy here, or
don't
take
do
your pick
anything,
as far as cutting balloons versus focal balloons.
7.5 दे दो
We will have to come into the main vessel here while we are stenting it. There's a significant disparity between the size of the main vessel and this branch. And using a BRS, where you will have limitation in dilating the proximal segment, would be a cause for concern?
You know, maybe or maybe not. This looks like an AP view. You know, if he does some angulation, you may lay out the bifurcation better. It looks as though you
थोड़ा
could
सा
land
angulate
this
कर देना उसको।
appropriately without necessarily going into the distal
hold
popliteal.
this
I'd like to see a slightly more angulated view. I think you can probably place it precisely enough to avoid that issue.
But
Yeah.
we need a little angle for that.
I'm going to make
Open up
it
this area.
more angulated जिसको LAO RAO कर दो थोड़ा
Yeah, you can play with your obliquity.
देखना श्याम follow करना don't यार please leave it छोड़ दो
Okay, there was a comment from a well-known
Holding?
authority in the field here that if it's heavily calcified, are you going to get effectiveness of the BRS? You're going to be able to expand it? Is that a good choice here, you know, if it's really that hard to dilate? Great question.
It didn't appear to be very calcified, but the way the balloon ruptured, maybe there was a spicule there. It doesn't appear to have a fluoroscopic calcification there.
I guess the best answer to that question is
दिखाओ
if you
यार।
can adequately predilate.
यार,
What the
क्या कर
data
रहे
would
हो
say
तुम,
is
श्याम?
if you can
यहाँ दिखाओ
achieve
ना।
proper predilation, then the
यहाँ
outcomes are
दिखाओ।
good. So the question is whether or not you can
कहाँ
achieve
है?
that. Yeah.
अटक रहा है.
Right, low radial force, apposition could
नीचे
be
दिखाओ.
questionable, it may not conform well.
नीचे
That's
दिखाओ.
where you have to make absolutely sure your predilation's excellent
Wire
and you
time.
have a good angiographic
please,
result
wire.
with
Wire ठीक है?
predilation before the stent's applied. I would agree, if you don't have that, maybe stay away. And their protocol may call for that. If you can't get adequate predilation, they may not want you to put it in.
बताना.
So that's a
I can't
question,
see this position.
question from the audience is, if you cannot adequately predilate, does that exclude the patient from BRS implantation?
आ गया?
It should.
Should.
Please move from here.
It was certainly true in the coronary trials.
And coronaries are much easier than the peripheral. So therefore, the
Okay.
question really
थोड़ा सा angulate करो.
is this a smart strategy in a patient who already has multiple stents?
7.5.
So tell me
So,
why BRS?
So as Dr. Vermani, she has concern that if you can't dilate this well, whether or not this is a good strategy here and whether or not you should use the BRS if you cannot predilate
Yeah.
well.
If I cannot predilate it properly, I will not use a BRS. We will end up using a balloon, just a balloon or maybe
Or maybe a
a
Zions.
drug-eluting balloon later on. But I think I can dilate it quite well. This balloon has opened very well. And I'm going to be here for about half a minute so that I do a good pre-dilatation, and then after that we are going to implant the stent.
How about it was commented a focal balloon or scoring balloon might assist you here if you still have trouble.
Yeah, I will use that if I don't get a good result here. I'm going to use a
And what,
Cutting
tell
balloon.
us what you're
Cutting
doing
balloon
right now,
radiation.
which balloon and how much pressure?
This is at 14 atmosphere, and this is a balloon from Thermo. This is a non-compliant high-pressure balloon, and we are at 14 atmosphere.
And is it still a 2.5 or bigger?
It is 2.75.
2.75.
What size BRS are you going to use there?
Okay.
The question is then, what size BRS?
I think I'm going to use 2.75 at least, but we will see. 2.75 is what we have decided.
Are you going to precisely
okay.
place it at the site
Yes,
of
sir.
the lesion or come back into the main vessel?
I would probably do it as precise as I can. We are going to open this up in different views.
What's better?
Come,
Definitely,
RAO?
it seems to have opened up.
Yeah, it looks better. Center.
Any concern
Little
that you
more
might
audio.
be undersized with a 2.75? Do you want to IVUS it or OCT it or anything? Or are you pretty confident with your visual
I
sizing?
think 2.75 is, I think so. This 2.75 would be the right size. Throw out audio. A little caudal.
Khanna, we have,
Yeah.
we're running out of time, please.
Okay.
Yeah, you got a good, 6 minutes?
Open up the vessel.
So I think this is a good view. We can probably go ahead and stent in this view. दे दो. 7.5. This was 15, na? 18.
What do you
So
say,
give us
precise
20.
placement or come into the main
You
vessel?
have 20 or 18?
I'm
19.
sorry,
Give
the
us
question
19.
again was?
Would you come into the main vessel or would you precisely place it just at the...
No, I think you can just go right to the ostium, maybe overhang a half millimeter. It looks like you can,
But that will make a huge difference because the sizing would be different.
yes, yeah, you don't want to go into the parent vessel here. You'll be undersized for sure. You don't want to be in the distal pop, which is going to be at least 4 or 5.
Yeah, I think you're going to end up with hanging struts with that strategy. So
You do not want to do that. Yes.
Yeah, good morning, chairpersons and Dr. Khanna. This is Dr. Anil Sharma from Bombay Hospital, Mumbai. First thing is, if you are planning to keep it in, as we
Yes,
are
Dr.
discussing,
Sharma.
main vessel, then is it okay to put a biobserval stents at the bifurcation? And there will be significant size discrepancy. What do you
Okay,
feel?
technical question. If you come back outside the ostium, what about size mismatch? And if you have to get into bifurcation stenting, would you use the BRS?
I think if you have to do a bifurcation
second.
strategy, it's better to use a normal drug-eluting stent rather than a BRS, or use a BRS plus a drug-eluting stent. 2 BRS would be a problem.
Yeah, the experience with this is of course, very limited, and I'm sure bifurcations are not part of this trial. In the coronary application, it's not been a
19,
great
2.75.
thing to do, and it's been done, but it's not necessarily encouraged. So I would say probably stay away from that. If you're dealing with bifurcation treatments, probably stick with standard coronary
Isko
stent
thoda
platforms,
back
which we
karna.
know do well and can be applied well in a variety of techniques.
Thank you.
What do you think here about that distal tendon lesion? Would you cover that as well?
I'm not sure I've seen it. Have we seen it?
There seems to be at least a moderate degree of disease distal to the ostium, distal to where they pre-treated.
Yeah, show it to us. After you stent it, we'll see a completion and have a look at it.
Hold the wire.
Didn't see anything super critical.
But I agree with your point. I think imaging here would be a nice supplement, both for the, to make sure that the sizing is precise.
With BRS usage.
Actually, we were planning to do it under OCT guidance, but there's some problem with the machine, so we are using now the eyeballing.
I'm sorry, we didn't quite.
With BRS technology, imaging is a must.
Is a must, yes. With BRS, the only good way to see it is with OCT. And, it seems to be a must. And, thankfully, at least in our country, in the United States, they're finally reimbursing OCT this year for coronary imaging. Up until then, it was a battle because there was no, quote, clinical outcome benefit, if you will. But now that this is approved in the coronary applications with BRS, you have to use it.
I think if we are not using an imaging, this patient with a significant disparity between vessel size, we shouldn't be putting a BRS. We should be going with a normal drug-eluting stent, post-dilate.
No, yes. If this was a true distal bifurcation lesion of the popliteal, then it's a whole different story. But this seems to be osteal, near osteal, maybe a millimeter in. I think this one's okay. As long as the challenge here is when you're going up and over, you have some slack, and when you deploy, it may move. So hopefully, they can control the actual deployment to make sure there's no motion.
नीचे एकदम नीचे जाओ यहाँ देखो
We're anxiously looking forward to this. There's about a minute and a half, couple minutes left here on transmission time. Hopefully get it into place and see the outcome.
Just go to a proper view now. And
so this is
a
275 by 18, I think I heard. Is that?
19. 275, 19. Okay, so we go distally.
Yeah, go in a little bit. Make sure you don't hang out into the popliteal.
Iliya nahi, sir.
Looks like a better view.
Looks okay.
That looks pretty good there.
Yeah, being able to lay out the ostium is critical here.
So, what do you say about this position?
I like it. I think that looks good.
I just have a feeling that the distal part of the balloon is in the block. Distal part of the stent, I mean.
Distal part of the balloon
is in the block. Either you should cover it.
I think it's right at the ostium.
No,
it is above
well,
the ostium.
The distal, I would really focus on the ostium, and then if you have to do an overlap, you have to do an overlap. But I think he's okay. I think you're good. I would go ahead.
Looks okay to me. Pressure कितना? हाँ? कितने तक? 0.5 कब तक? So again, the implantation technique is the same. We go at an increment of half-half atmosphere at every 5 to 10 seconds.
Dr. Srinivasan, your talk is next, so be ready.
So we're anxiously awaiting this. Our transmission time is about up.
Prepare किया था?
So we'll
So
look
no
forward to
imaging
this.
and no fluoroscopy and no live transmission. So we'll wait for the final results after a
Yeah,
couple
we're
of
going to
months.
wait for your result. We want to see how this turns out.
In the meanwhile, we have a talk with Dr. Srinivasan. Dr. Srinivasan, please.
So tell us, how high did you go for how long? Are you going back up?
Right now we are at 6 atmosphere. We went up very slowly. Every 5 to 10 seconds we went up by one atmosphere.
Yep, slow,
कितने
gradual.
तक जा सकते हैं?
Size looks actually pretty good.
So the nominal is 9. So we are at 8 now. Actually now we can be going up rapidly. So this is 10. I'm going to put it there for about 30 seconds. Okay.
All right, let's do an angiogram, see how it looks. We're
Okay. So looks good.
oh, very good.
मैं कर दो और DSA कर दो.
Not bad.
Sir, पैर मत हिलाइएगा पिल्लई साहब. Just hold your leg, okay? We are done.
Can you do it under DSA so we can see?
Okay.
Distal end doesn't look good.
Yeah, I'm doing that.
No, we'll see. Let's see.
दिखाओ मुझे.
It's right over the
is funny.
periosteum. Let's do it digitally subtracted.
नहीं चला. 1 second. Ready? We are trying to get the DSA on this. DSA on? So this is how it looks.
Yeah, there is a
Maybe
distal edge.
distally, proximally we may have to dilate a little more.
Distal edge.
Distal edge.
Yeah, that was, I think,
Distal edge, I think it's an overlap. Come
the
AP,
disease that may
we'll
have
see it in other view.
pre-existed there. So
Yeah, I think you do have a lesion there. Huh? A distal edge stenosis. But anyway, the stent itself expanded well and looks good. Now you have to deal with that distal
Dr.
edge.
Srinivasan, please.
Okay.
Okay, I think with that, that was a very interesting demonstration of a new technology here in its application below the knee. Look forward to seeing the final result. We'll do this lecture and maybe you can just give us a quick shot and show us your final after you deal with that distal edge. Thank you very much.